Hi, everyone. Welcome. Today, it's my pleasure to introduce Dr. Awan, who's a musculoskeletal radiologist at the University of Maryland. He is also the Associate Program Director and also serves as the Associate Vice Chair for Education. He has a ton of rewards and accolades, which you all can look up. I just want to say that I've personally got to experience his virtual lectures multiple times before this, and he just has a way of making it so that even if there's a topic or a subject that you thought you weren't interested in, after he speaks, you are going to want to learn more about it. So without further ado, it's my pleasure to welcome Dr. Awan, and I'll let him take it away.
Thank you so much, Amina, for the nice words. I appreciate that. Okay, so today what we're going to do is we're going to talk about arthritis. Okay, this is a bread and butter topic for residents, trainees, medical students. So hopefully this will be somewhat useful for everyone here. I'd like to start all of my lectures with some cases, some unknown cases that we're not going to discuss now, but we're going to come back to at the very end of the lecture. So I promise you will see all these 5 cases at the end. So this is case 1. It's obviously a form of arthritis. And there's a question with each case. So this patient will most likely, you guys can read this on your own and kind of think through. So this is the image again, and this is what the question was. Okay, this is case 2. This is a cone down view of obviously the inter-IP joints, showing a different form of arthritis from case 1. And this is just what's the most likely diagnosis based on that single radiograph. Case 3 is just a discrete question. The hallmark of inflammatory arthropathies is there's one finding in here that is central to all inflammatory arthritises. And what is that finding? Okay, that's number 3. Number 4, this is a cone down view of the wrist, showing a radiographic finding. And that finding can be seen in all the following except which arthritis. So 3 of these 4 arthritises will have the finding that I'm showing here, and 1 does not. Which one does not? Okay, and finally, this is images of bilateral hands and wrists. And the question is going to be, what's the most likely diagnosis for this arthritis that you're seeing here? Okay. And I promise we'll come back to these at the end of the lecture. Hopefully you guys will be able to answer all of these questions at the end of the lecture. Okay, so what we're going to do today is we're going to just describe a basic algorithm to evaluate arthritis, which I think is very helpful in stratifying all the arthritides when you're examining them radiographically. Discuss the difference between inflammatory and degenerative arthritises. I think those are the 2, overarching categories for arthritis. Deciding is it degenerative or is it inflammatory? And we're going to give specific examples of each of those and then talk about the imaging findings with all of those arthritises. And you're only going to see plain films today. Unfortunately, you're not going to see any CTs, you're not going to see any MRIs. We do use CT and MRI to evaluate arthritis, but really the mainstay of evaluation for arthritis is a plain film, because that's what we do in general practice, right? So I really want to just show you guys plain films, and quite frankly, plain films are hard to interpret, right? In my opinion, I think cross-sectional imaging is very easy to interpret, but plain films is a little bit tougher. So that's what we're going to spend most of our time looking at: radiographic manifestations of arthritis. And this is an algorithm that I stole from a radiology article from John Jacobson. I think this is fantastic. It really outlines exactly how you should approach arthritis. I tell my residents and med students to memorize this algorithm because it's that good. So all arthritises are going to have joint space narrowing. When you say joint space narrowing, that tells you nothing about the arthritis. It just means that arthritis is present, right? But then really what you want to do is you want to stratify and ask yourself, well, is it a degenerative process or is it an inflammatory process, right? And the difference is, I think a good way to understand it is degenerative arthritises make more bone, right? Like through osteophytes, right? There's bony proliferation through osteophytes. Whereas inflammatory arthritis is you're losing bone in the form of erosions. There's loss of bone, right? So I think that's a very central initial way you should approach arthritis, right? So all degenerative arthritis are going to have osteophytes and proliferation of bone. All inflammatory arthritis are going to have loss of bone in the form of erosions. Now, there are other differences. So for example, the joint space narrowing tends to be symmetric in inflammatory arthropathy. So for example, in rheumatoid arthritis, you get joint space narrowing of the entire joint. That's what we mean by axial joint space loss in the hip, right? Whereas in degenerative arthritis, it's going to be asymmetric. For example, in osteoarthritis, right? The joint space narrowing of the hip is really only going to be superior lateral. It's not going to involve the entire circumference of the joint, right? There's other findings, like subchondral sclerosis in degenerative arthritis, and other findings like subchondral cysts. Those are seen in degenerative arthritis. In inflammatory arthritis, you're always going to have usually soft tissue swelling, periarticular osteopenia. Those are findings seen in inflammatory arthritis. But the hallmark finding of inflammatory arthritis is erosions. The hallmark finding of degenerative arthritis is proliferation of new bone through osteophytes, okay? And in terms of degenerative, the vast majority of degenerative arthritis are going to be OA. 95% of the cases that you see in practice that are degenerative will be just typical classic OA DJD. But sometimes you can have atypical arthritis if it's in a distribution where you wouldn't expect it in OA. The age is different, the severity is different. Then you can have things like post-traumatic arthritis, CPPD, pyrophosphate arthropathy, and so forth. In terms of inflammatory arthritis, if you have one joint involvement, it's septic arthritis until proven otherwise, right? If all the joints are normal and only one joint is involved with erosions, it's septic, it's infection until proven otherwise. Otherwise, if you have multiple joints, you're looking at rheumatoid arthritis or the 4 seronegative HLA-B27 spondyloarthropathies, right? And the way to differentiate those are through distribution. Usually RA is proximal, the seronegative spondyloarthropathies are distal, and also something that we're going to talk about later, which is called periostitis, which is seen, or bony proliferation, which is seen in seronegative spondyloarthropathies and is not seen in RA. So I think this is a very helpful algorithm to kind of demystify and approach the various forms of arthritis, right? And the difference is, I think we already talked about it, right? In inflammatory arthritis, you lose bone through erosions, right? The joint space narrowing is symmetric. And of course, in degenerative arthritis, you produce more bone. Now, before I get into them, I want to talk about the types of erosions, because I think understanding the types of erosions helps trainees stratify the arthritis even more. So there are 3 types of erosions in the hands: marginal, juxtaarticular, and central, based on the location in the joint, right? So for example, marginal erosions, which happen along the periphery of the joint, you can see erosive change here and here along the periphery of the joints, right? This happens in rheumatoid arthritis classically. It also happens in psoriasis and reactive arthritis, but classically it happens in rheumatoid arthritis because you have the synovial pannus and inflammation that erodes the bare ends of the joints that are not protected by cartilage, right? So those areas are more predisposed to getting marginal erosions. And your differential for any marginal erosion in the hand would be these 3 things right here: rheumatoid arthritis, psoriasis, reactive arthritis. That is your differential for marginal. Of course, septic arthritis can result in any type of erosion, but outside of septic arthritis, rheumatoid arthritis, psoriasis, and reactive arthritis are your 3 causes of marginal erosions. Juxtaarticular erosions are when you have erosions not at the periphery, but kind of just outside the joint, right? It's like just kind of away from the joint capsule, right? And they tend to be very well defined with sclerotic margins, sometimes overhanging edges. This is pretty much only seen in gout. When you say the word juxtaarticular, if you're on the phone with me, if a resident is on the phone with me and they say that, hey, there's a plain film, there's a juxtaarticular erosion, I automatically know that it's gout, right? Because you use the buzzword for gout. Now, obviously, end-stage rheumatoid arthritis, like very, very end-stage, can also result in juxtaarticular erosions, but that's not very common. Pretty much, if you see an erosion that's just outside the joint, that's very well defined with sclerotic margins, you're talking about gout. Okay, and that's really the only differential diagnosis for juxtaarticular erosion. And now the last type of erosion is a central erosion, where you have an erosion along the center of the joint. Okay, and that's classically seen in erosive OA. In older females that have arthritis and that end up getting erosions, you get this kind of seagull appearance that you're seeing here, right? This is what erosive OA would look like. Now, psoriasis and reactive arthritis can also have central erosion. So remember, psoriasis and reactive arthritis can have both central and marginal erosions. Okay, they're the 2 types of arthritis that can have erosions in different areas. Okay, so that's your basic differential for both for central, marginal, and juxta-articular erosions. Degenerative arthritis typically result in asymmetric joint space loss. Okay, the whole joint is not usually involved in joint space loss, and unless it's end stage, right? You don't have erosions, you don't have that loss of bone. In fact, you get osteophytes or proliferation of bone. You can have other things like subchondral sclerosis and subchondral cystic change. In terms of examples, this is a list of some of the more common inflammatory arthritises, right? Septic arthritis, RA, the seronegative spondyloarthropathies, gout. Okay, those are things that you should be thinking about. Degenerative arthritises are like OA, post-traumatic arthritis in a young person that's had a fracture, neuropathic osteoarthropathy, CPPD arthropathy, pyrophosphate arthropathy. These are the types of degenerative arthritises that are common. Okay, only going to talk about things that are very common and applicable in clinical practice. So now let's go into the radiographic manifestations of these different types of arthritises. Okay, and again, we're only going to really focus on radiographs because that's really the mainstay of evaluation. We of course do MRI to look for early erosions in rheumatoid arthritis and other findings like tenosynovitis, synovitis and things like that. But we're going to focus really on plain film characteristics. So septic arthritis, we'll start with that. This is of course an inflammatory arthropathy. It represents infection of the joint, right? It's usually hematogenous from Staph aureus. Patients typically have fevers, chills, elevated ESR rates, and the findings really are destruction of that joint, right? So joint space loss, erosions, osteopenia, soft tissue swelling. You may have gas, right? This is a nice example of what a PIP joint septic arthritis would look like. You have marked soft tissue swelling, you have periarticular osteopenia. The bone is demineralized around the joint, but not away from the joint, right? And then you have an erosion. You have this like kind of dorsal erosion, around the joint, right? It's very ill-defined. This is not a typical gouty erosion, right? Because a gouty erosion is very well defined, right? With sclerotic margins and overhanging hedges. This is very ill-defined, right? So this is a nice example of what septic, and the rest of the joints are normal. That's the key, right? You look at it, you look at this, the rest of the hand is completely normal, but only one joint is involved and it's swollen. There's erosions, septic arthritis until proven otherwise, okay? An example in the ankle, soft tissue swelling, periarticular osteopenia. The mineralization of the bone is decreased around the joint, but not away from the joint. And you have these ill-defined erosions along the talar dome, medially and laterally. The rest of the joints look normal. Patient has fever, septic arthritis until proven otherwise, right? I think that's very straightforward. Hopefully that was understandable to most of you guys. Moving on to rheumatoid arthritis, which is the most classic prototypical example of an inflammatory arthritis, right? This happens in young to middle-aged females mostly, okay? Obviously men can get rheumatoid arthritis, but it's much more common in females, okay? High association with rheumatoid factor, right? Other ANA antibodies. It can affect a lot of things like the joint capsule, the tendons, the bursae, things like that, right? But in terms of radiographic manifestations, you're looking at something that's usually bilateral, symmetric, right? So it's going to involve not just one hand, but both hands, right? And proximal distribution, right? Almost never involves the DIP joints in the feet or the hand, okay? Typically involve the radiocarpal joints, the carpal joints, and the MCP and the PIP joints. Now, it can involve the DIP joints, as you're going to see in a second, right? In end-stage disease, when the patient has had, it's poorly controlled, and the patient has had it for years and years and years, it will eventually go to the DIP joint, but not initially, right? It will definitely not involve the distal interphalangeal joint initially. And the findings are, of course, soft tissue swelling, periarticular osteopenia, which are seen in all inflammatory arthritises, but the erosions are marginal for the reason we talked about, right? The pannus formation that destroys the bare end of joints that aren't protected by cartilage, okay? This can be seen in the knees, SI joints, glenohumeral joint, in a lot of different joints in the body. This is a nice example of what RA would look like. In fact, I think this was case 5 of the first, of the quiz that I showed at the beginning, right? Notice that there are a lot of erosions, predominantly at the wrist, right? The radiocarpal joint is involved, the intercarpal joints are involved. All these lucencies are erosions, right? You can also see erosions. The second and third MCP joints and the second PIP joint are very important joints to look at in RA. Okay, these three joints, second and third MCP and second PIP joints, those tend to be involved in RA. You can see the marginal erosions here, the soft tissue swelling here, but I want to point your attention to actually erosions at the DIP joint, like right there and right there, right? It can happen, right? In end stage, this person has had rheumatoid arthritis for a very long time. You can end up getting it, but you would not expect that initially. And certainly on a board exam, you know, the ABR core exam, they would not show you an erosion in the DIP joint as a manifestation of rheumatoid arthritis, right? But I'm just showing you real life examples where it can happen, okay? This is an example of a large erosion here along the scaphoid at the radiocarpal joint and along the radial styloid. Classic places to get rheumatoid arthritis. The ulnar styloid, also another very important place where you can get an erosion. In fact, people have said, and authors have said, that the ulnar styloid is the first place that can be affected in rheumatoid arthritis, right? So always look at the ulnar styloid very carefully and make sure it's not eroded. In the knees, again, look at the symmetric joint space loss, right? The entire medial and lateral femoral tibia compartment is involved, and you have these marginal subtle erosions, which I think are hard to appreciate on this, but you can take my word that there are some subtle erosions here. But you can see very clearly the symmetric joint space loss in RA. Moving on to psoriatic arthritis, we're going to go through these relatively quickly because there are a lot of arthritises that I want to kind of, you know, just give you an overview of. We could spend all day on just rheumatoid arthritis. It's that complicated, right? But I want to give you kind of an overview of all the most salient features of the different arthritises. So psoriatic arthritis is an HLA-B27 seronegative spondyloarthropathy, right? As is reactive arthritis, as is IBD, as is ankylosing spondylitis, right? So psoriasis is radiographically identical to reactive Reiter syndrome or reactive arthritis, okay? You can't tell them apart radiographically for the most part. Now, clinically, they're completely different, right? They're completely different. So clinicians already know if a person has psoriasis or reactive arthritis, right? But if we don't know, if we have no history on the patient and we're seeing findings, we're gonna, if we mention psoriasis, you should always mention reactive arthritis and vice versa, right? So that's very important to keep in mind. Now, psoriasis can be unilateral, it can be bilateral. Remember, RA was usually always bilateral and symmetric, but psoriasis can be unilateral, it can be bilateral, it can be symmetric or asymmetric even. But the key to psoriasis is understanding that the distribution of the arthritis is typically distal. So you're not going to really see it at the carpal bones, right? In the wrist, you're going to see it in the PIP and the DIP joints in the hands, okay? Typically, you can see it has an axial distribution, so usually the spine is involved, right? Maybe the hips, the shoulders, but sometimes you can have ankle, elbow involvement as well. The findings, again, are soft tissue swelling, periarticular osteopenia, not always periarticular osteopenia, but that can occur. But the erosions aren't just marginal, they can also be central, as I talked about earlier, right? You can have central erosions and marginal erosions in both psoriasis and reactive arthritis. A key finding that a lot of residents don't understand, in my experience, training residents, is this finding of periostitis or fluffy new bone formation around the joints. That's a finding that's only seen in seronegative spondyloarthropathies. You will never see periostitis in RA. You won't see it in pretty much any other arthritis. But periostitis or fluffy new bone formation is a finding, or whiskering. At AIRP, they often talk about, like Dr. Murphy talks about whiskering of the bone, right? That is seen really only in the seronegative spondyloarthropathies. And it's a very helpful finding if you see it, because you can narrow your differential diagnosis down. You can now also have like sausage digits, arthritis mutilans, destruction of the joint, pencil and cup deformities. Those are also very central to psoriatic arthritis. So here, this is a nice example of what like a pencil and cup deformity would be. Like you have saucerization of one bone telescoped into another bone. You have central and marginal erosions. You have soft tissue swelling, all findings, subluxations here, all findings of psoriatic arthritis. You have marginal erosions here and soft tissue swelling in a distal joint compatible with psoriatic arthritis. Central and marginal erosion, soft tissue swelling, distal joint compatible with psoriatic arthritis. This is what I mean by periostitis, this kind of fluffy new bone formation. Look at like very subtle periosteal reaction here, here. You may have to squint, but here, here. Actually, in a lot of places, that's a very helpful clue. It's not, it can be more dramatic than that, but in this case, it's very subtle, right? But that's a very helpful clue that this could be a case of psoriatic arthritis. Notice that you don't have erosions. This is proximal, right? These joints are proximal, but you do have periostitis, right? You have periostitis, which is a helpful finding for psoriatic arthritis. Kind of marginal erosions here, soft tissue swelling involves the MTB, but also the PIP, more distal distribution, kind of some subluxation, right? Lateral subluxation of the middle phalanx with respect to the proximal phalanx. Nice example of psoriatic arthritis, right? Some periostitis here, erosions, soft tissue swelling, distal, psoriatic arthritis. I hope you get the picture. Multiple erosions, distal distribution, periostitis. Always think about psoriatic arthritis. This is another key finding that I haven't discussed yet. This is known as paravertebral ossification in the spine. This represents ossification of the paraspinal soft tissues, typically is comma shaped, and it goes from kind of like a midvertebral body to a midvertebral body. Okay, so this paravertebral ossification is only seen in psoriasis and reactive arthritis. This is not seen in Angst-Bahn or IBD arthropathy, and I'll talk about what's seen in those two arthropathies. But when you see paravertebral ossification, ossification of the paraspinal connective soft tissues from mid-spine vertebral body to the other mid-vertebral body in a comma shape, always think about psoriasis. I think it's very helpful because it's only seen in psoriasis and reactive arthritis. So Angst-Bahn, right, which is radiographically identical to IBD, but totally clinically different, are the other two seronegative arthropathies. HLA-B27, almost highly seen in males, much less common in females. Typically males are in their 20s or 30s when they get diagnosed with Angst-Bahn. So again, axial joints like the spine, SI joints are the ones that are very common, right? Typically it's bilateral and symmetric, and you get erosions, right? So you get like sacroiliitis and erosions along bilateral symmetric SI joints, soft tissue swelling, osteopenia, that all is there as well. Now, instead of paravertebral ossification, you get something called syndesmophytes. And again, syndesmophytes are only seen in Angst-Bahn and IBD arthropathy. And this represents ossification of the annulus fibrosus of the disc. And I'm going to show you what this looks like in a second. But I want to show you first SI joint sacroiliitis, which is erosions. You can see the lucencies here at the SI joints. It's bilateral, it's symmetric, and you have like subchondral sclerosis and joint space loss. And eventually you'll get ankylosis of these SI joints, right? So this is a nice example of what sacroiliitis would look like in AS. This is what syndesmophytes look like. So you get like bridging bone from the corner of a vertebral body to the corner of a vertebral body. Remember, it's not comma shaped and it's not going mid-vertebral body to mid-vertebral body like in psoriasis or reactive arthritis. Syndesmophytes, which are only seen in Angst-Bahn and IBD, which represent ossification of the annulus fibrosus of the disc, corner of vertebral body to corner of the vertebral body. You also see some fusion of the facet joints and ankylosis, which is typical of Angst-Bahn. Okay. Again, you're seeing syndesmophytes here, corner to corner. You don't have the huge comma-shaped stuff that are going outside of the scope of the vertebral body. Okay. This is known as the dagger sign, right? Fusion of the interspinous ligament, another classic sign in Angst-Bahn. You can also have something called the trolley sign, where you get not only fusion of the interspinous ligament, but fusion of the facet joints on the sides, right? And that would be the trolley sign. But this is a nice example of what the dagger sign or fusion of the interspinous ligament will look like, seen very commonly in Angst-Bahn and IBD arthropathy. Okay, so those were a lot of the inflammatory arthropathies that I want to discuss, and I want to move on now to degenerative arthropathies. And the classic hallmark arthritis involved in degenerative is osteoarthritis, which will be like 95% of the cases that you see that are degenerative will be just classic OA, DJD, typically in older people, females, postmenopausal females. Okay, this happens as a result of aging, chronic wear and tear, repetitive microtrauma, cartilaginous injury to the joints. Almost all of us will get this unless we're lucky, genetically. Typically, it results in asymmetric joint space loss. So usually the whole joint is not involved unless it's end stage. So for example, in the knee, typically the medial femorotibial compartment is involved more than the lateral femorotibial or the patellofemoral compartment. But obviously, I'm sure you guys have all seen x-rays where all three compartments are involved, right? And that happens in end-stage OA. But initially, usually the medial femorotibial compartment is more classically involved. And you get joint space loss, subchondral cysts, subchondral sclerosis, and of course you get osteophytes or proliferation of bone, which is the hallmark finding of any degenerative arthropathy, right? Now, the joint space loss can be symmetric very rarely, like in the hands, like the MCP joints and the IP joints, but more commonly it's asymmetric. That's a exception to the rule. Okay. In the knee, we kind of talked about this. It'll usually involve the medial compartment, or in patients that are young that have patellar maltracking disorders, it can involve the patellofemoral compartment more, but that's rare, right? That's in young people that have patellar maltracking disorders. Also can involve the lateral compartment more if the patient has like a genu valgus deformity, right? But again, that's rare, right? Usually it'll involve the medial compartment more. The key is that it's usually going to be asymmetric. It's not going to be symmetric. In the hip, it's usually going to be, the joint space loss is going to be more superior lateral. In the shoulder, it's going to be more posterior, right? So you can get the sense that osteoarthritis and these degenerative arthritises result in asymmetric joint space loss. Another very important point that sometimes trainees don't quite get. All right, this is an example of what OA would look like. PIP, DIP joints, distal distribution, joint space loss, subchondral sclerosis, spurring, and osteophytes, right? Classic example of what OA would look like in any hand. Okay, in the wrist, the two most commonly involved joints in the wrist of OA are the triscaphe joint right here between the scaphoid, trapezium, trapezium, which we don't see that much involvement, but the first CMC joint as well, which is very involved here, right? With the joint space loss, the osteophytes, and the subchondral sclerosis, and even the cysts, right? So the first CMC and the triscaphe joint are by far the two most commonly involved joints of OA in the wrist, right? I wouldn't expect radiocarpal involvement for classic OA. Now, if it's post-traumatic OA and they've had a distal radial fracture, then yes, you can get post-traumatic osteoarthritis in the radiocarpal joint, but not standard primary osteoarthritis. Would not really involve the radiocarpal joint, okay? In the knees, classically, the medial compartment will be involved more. You can see the lateral is relatively spared, but immediately we have joint space loss and osteophytes, classic for traditional OA, okay? In the hip, superior lateral joint space loss, but nice joint space more medially and inferiorly, and marginal osteophytes, subchondral sclerosis. Classic example of what OA would look like in the hip. Okay. Now, CPPD or pyrophosphate arthropathy is associated with, crystal deposition. It has the same findings of degenerative arthritis, except the location is different. So you're going to have subchondral cysts, subchondral sclerosis, joint space loss, osteophytes. You may or may not have chondrocalcinosis, right, which is calcification, in certain spaces like the TFCC, the ligaments, the joint capsule. But the distribution is going to be different. So for example, in the wrist, it's not going to involve the first CMC or the triscaphe joint like OA does, but it's going to involve the radiocarpal joint. The radiocarpal joint is the one that's going to be involved in CPPD. And it also involves the second and third MCP joints in the hands, okay? In the knee, the patellofemoral compartment is going to be involved more than the medial compartment, right? So in OA, it's the medial femorotibial compartment that's involved, but in the knee, it's the patellofemoral compartment, right? So the distribution of degenerative changes is going to be different, which will lead you to the diagnosis of pyrophosphate arthropathy versus OA. Chondrocalcinosis, which we kind of talked about, which is, you see it here, like the calcification in the TFCC or the triangular fibrocartilaginous complex. Sometimes you can see it in the lunato-tricrucial ligament in the joint capsule here. This has a differential. This is not just seen in pyrophosphate arthropathy. It is certainly seen in pyrophosphate arthropathy, but it's also seen in things like hemochromatosis, Wilson's disease, even OA. You can have chondrocalcinosis. People forget that, right? So then people always ask me, nurses always ask me, well, if you have chondrocalcinosis in the wrist, then how do you differentiate it from OA and pyrophosphate arthropathy? The key, again, is the distribution, right? If I see degenerative changes at the radiocarpal joint, it's pyrophosphate arthropathy. If I see degenerative changes at the first CMC joint and the triscaphe joint, the answer is OA, right? So it's the distribution is going to lead you to the correct diagnosis. This is a nice case of pyrophosphate arthropathy, chondrocalcinosis, and the degenerative changes that predominate here at the radiocarpal joint, the joint space loss, subchondral sclerosis, a little bit of cystic change as well, some spurs and osteophytes, Nice example of what pyrophosphate arthropathy would look like. In the knee, chondrocalcinosis in the menisci, but notice that the patellofemoral compartment is more heavily involved than the medial or lateral femorotibial compartments. Another nice example of, you wouldn't call this OA, you would call this pyrophosphate arthropathy, right? Neuropathic arthropathy is another degenerative type of arthropathy that's typically seen in like diabetic patients, patients that have syphilis or neurologic dysfunction. It leads to degenerative type of changes, and it leads to joint instability and fragmentation. And the findings really are destruction, increased density, subchondral sclerosis, subluxation, debris, all those things. The joint really looks kind of nasty and ugly, quite frankly. We see this very commonly in the midfoot in diabetics. So this is a nice example of what a neuropathic joint would look like. You can see the, debris, all these ossific fragments, subchondral sclerosis, some destruction of the bone here. You can see sort of a rocker bottom foot deformity with, plantar subluxation of the talus. You can see a pes planus or flat foot deformity with, decrease in the calcaneal inclination angle. You can see some soft tissue swelling. Just this looks classic for what a neuropathic or, neuropathic osteoarthropathy or Charcot joint would look like. Okay, very common in the foot, especially in diabetics. Again, you can see this. You can see all this destructive changes. Sometimes you can get Lisfranc, subluxation or dislocation. You always want to look at the Lisfranc alignment here at the TMT joints. All this sclerosis, cystic change, debris, disorganization, soft tissue swelling, predominantly along the midfoot in a diabetic, classic for neuropathic osteoarthropathy. Hemophilia is one of the last arthritises I want to talk about this morning. And this is typically seen in younger people, in pediatric patients, right? And it really represents intra-articular hemorrhage. When hemorrhage becomes deposited in a joint, it results in destruction. And although this is classified as a degenerative arthritis, some people classify this as, inflammatory too, because there are some, you can get erosions, you can get destruction of the joint. So, but you do have a lot of degenerative elements in it as well. So there is some debate as to whether it's degenerative or inflammatory. And, it's not really that important to know what is what, right? Just as long as you can identify that it's hemophiliac arthropathy. But typically you can get subchondral cysts. The classic findings are dense effusions because you have blood in the joint space. So dense effusions. And in pediatric patients, you can get epiphyseal overgrowth, ballooning of the epiphysis, and in the knees, widening of the intercondylar notch. Those are the classic hallmark findings of hemophilia. You can also get a hemophilia pseudotumor, which is like a large cystic area in the bone itself. So this is what I mean by widening of the intercondylar notch. Look how wide this is, right? You also get joint space loss, subchondral sclerosis, some spurs. A nice example of what the physes are like kind of just closing here. You have the physeal scar. Nice example of what hemophiliac arthropathy would look like. Notice the dense effusions here in the ankle, right? They're very dense, right? This indicates that there's hemorrhage in a pediatric patient, likely hemophiliac arthropathy, okay? So that's kind of in a nutshell how I want you guys to approach arthritis, okay? I want to come back to this algorithm because I think it's that important. I think it's that important for you guys to understand kind of a gestalt of how arthritis is characterized. So again, joint space narrowing is seen in all arthritises, not just DJD, right? But the key is the joint space narrowing symmetric or asymmetric? If it's symmetric, you want to be thinking about an inflammatory arthritis. If it's asymmetric, you want to be thinking about a degenerative arthritis, right? The hallmark finding of inflammatory arthritis is loss of bone through erosions. The hallmark finding of degenerative arthritis is production or proliferation of bone through osteophytes, right? And then typically for degenerative arthritis, classic OA is going to be 95% of your cases. You can sometimes have atypical arthritis, which we talked about. Inflammatory arthritis, if it's one joint, it's septic arthritis until proven otherwise. If it's a systemic disease and there's more than one joint, it's either RA or the seronegative arthropathies. Remember, RA has more proximal distribution. The seronegative arthropathies tend to have more distal distribution in the hands. And remember that periostitis or fluffy new bone formation or whiskering is only seen in seronegative arthropathies and not rheumatoid arthritis. Okay. And this is just kind of like a nice cartoon of the distribution is key, is king when it comes to arthritis. So remember, rheumatoid arthritis, radiocarpal, drudge, MCP joints, and the PIP joints typically are the second and third digits, right? That's classic for RA. DJD in the hands, typically PIP, DIP, and as we said in the wrist, triscaphy and first CMC joint. Inflammatory arthritis is going to have the same distribution as DJD, but just there's going to be central erosions. Okay. Pyrophosphate arthropathy typically involve the radiocarpal joint and sometimes the second and third MCP joints. Okay. Psoriatic arthritis is going to have distal distribution, and gout can really involve any joint, but classically involves the first MTP joint in the foot and the CMC joints in the wrist/hand. Okay, but gout is actually the one arthritis that can really involve any joint in the body. All right, let's come back to the first cases, and I want to see if people get this, right? So I'm going to open up the chat here and see if people are getting these answers correct. Okay, so I want to see what people say here. So this is one arthritis that we went over. Look specifically at the fourth PIP joint, and what would you think? Oh, I just answered the question for you. I'm sorry. So the patient obviously most likely has positive HLA-B27. This is psoriatic arthritis, right? Because you have a pencil and cup deformity, central and marginal erosion, soft tissue swelling in the PIP joint, more distal distribution. Okay, so this was an example of psoriatic arthritis. The patient would test positive for HLA-B27. All right, this is another image here. Okay, this is a cone down view of the hands. Okay, you're looking at the PIP and DIP joints. What is the diagnosis here? Is this OA, RA, psoriasis, CPPD, or erosive OA? And it looks like a lot of folks are saying OA, which is the correct answer, right? This is a classic case of osteoarthritis where you have PIP, DIP joint involvement with osteophytes, subchondral sclerosis, cystic change. We see no erosions here. Nice example of what OA is. All right. What's the hallmark finding of inflammatory arthropathies? Is it asymmetric joint space loss, proliferative bone formation, subchondral cyst formation, soft tissue swelling, or erosions? What do we see in all inflammatory arthritises? Looks like most people have said E, which is erosions, which is the correct answer. Remember, inflammatory arthritis is you lose bone in the form of erosion. Now, soft tissue swelling is correct, but it's not the hallmark finding. Of course, you can get soft tissue swelling, but you can get that in a lot of things, right? So, but erosions we see as a hallmark finding of all inflammatory arthropathies. All right, this is case number 4. We see a wrist x-ray. We see a radiographic finding here. Okay. So there's something here and here. So this finding is seen in all the following except what? Do we not see this in CPPD arthropathy? Do we not see this in RA? Do we not see this in hyperparathyroidism? Or do we not see this in hemochromatosis? Okay, I like Robert Irwin and Muhammad Hamid's answer. Rheumatoid arthritis. We don't see chondrocalcinosis in RA, right? So this is chondrocalcinosis or calcification within fibrocartilaginous structures like the TFCC. We can see that in pyrophosphate arthropathy, and we can certainly see that in hyperparathyroidism and hemochromatosis, but we can also see this in Wilson's disease. We can see this in OA even, but rheumatoid arthritis is not classically linked to chondrocalcinosis, okay? So that's just a radiographic finding that can actually be seen in multiple arthritides, not just pyrophosphate arthropathy that as is classically taught. And then finally, the last case, this was a case I showed earlier, bilateral hand radiographs, okay? The question is gonna be, what's the most likely diagnosis based on the findings that you see, okay? Is it RA, psoriasis, erosive OA, OA, or CPPD arthropathy? Calcium pyrophosphate deposition arthropathy. Which one is it? Some people have answered this. Some people have answered this RA, and that's correct. You have more proximal distribution of erosions. The second MCP and the second PIP and third PIP are involved. There are some distal erosions, but the hallmark finding are erosions. There's no periostitis. There's periarticular osteopenia, soft tissue swelling. This is a nice example of what RA would look like in clinical practice. So I hope what we did today, we ended early, which is great. We discussed a basic algorithm to differentiate inflammatory and degenerative arthropathies. We discussed what the difference is, erosions versus osteophytes, essentially. We talked about examples of the different types of inflammatory and degenerative arthritides, and then we did sort of a gestalt radiographic overview of what the different, more common forms of the different types of arthritis look like. I hope this has given you somewhat of a nice overview in your approach to evaluating different forms of arthritis. Thank you so much for your attention. I'm happy to take questions now.
Awesome. Okay, thank you so much, Dr. Awan, for that awesome presentation. Yeah, we have a couple of questions in the chat. So I will just tell them to you one by one, and we can go through them. So the first question is, when do you recommend the use of MRI in arthritis?
So we typically use MRI as like a problem-solving tool, or, you know, for example, some young, like for example, in rheumatoid arthritis, young female patients can come to us and their radiographs are normal, right? But they have positive RF factors. They have the clinicians are, the rheumatologists are suspecting RA. So MRI can show early findings like early erosions, right? Early synovitis, tenosynovitis around joints, right? Inflammation, inflammatory things. So, you know, it can diagnose RA quicker than, and ultrasound too, for that matter, than radiographs. So typically we use it as a problem-solving tool or to diagnose early arthritis that we can see radiographically.
Okay, perfect. And then the next question was, how can we differentiate psoriatic arthritis from erosive OA when the DIP joints are involved?
Yeah, that's a great question. So it's not always easy. Sometimes you have to give a differential, obviously, right? We can't always know, but typically we won't see periostitis in erosive OA. Remember the fluffy new bone formation and whiskering that we see in psoriatic arthritis. And sometimes if you have marginal erosions as well, you know what I mean, and pencil and cup deformities or arthritis mutilans, and you have, if you look at the spine, that can be helpful. But sometimes you just look at the patient population. Is it an older female versus someone that's a little bit younger? You know what I mean? That can help as well. The clinical profile is very helpful. But again, if you don't have that information, sometimes you just provide a differential. I've done that before. There have been times I have put psoriasis and erosive OA in my differential in my report, and I can't tell the difference. But oftentimes we can if we have clinical information and things like that.
Perfect. Okay. And then someone had typed in here case 5A. If you want to just, I can go through the other questions and we can come back to that one.
Sure.
So let's see. Do you still use the Kellgren and Lawrence system for classification and reporting of osteoarthritis?
I don't. I try to not use systems when I do reports. That's just my personal preference, right? Even things like, for example, like Schatzker classification of like tibial plateau fracture. I don't like say Schatzker 6. Like I just describe, because a lot of the purpose of a report is for your clinician to understand what the heck is going on with your patient, right? So if you're using words that no one understands except us, right? I don't think you're doing a service to the clinician or the patient, right? I mean, that's, again, this is my personal opinion. So my reports are very concise, they're brief, and they just describe the findings and describe what the implications are for it. I don't like to go into classifications, and that's just my opinion.
Okay, perfect. Let's see. I'm not quite sure about this question. Let's see if I can decipher. It says, in the study of arthritis, the X-ray films are comparatives. If whoever wrote that question wants to clarify, and I can come back to that. Let's see. The next one was, can you say a few words on tuberculous arthritis?
Sure. Yeah. TB arthritis is an inflammatory arthritis for sure. You're going to have erosions. It can be an example of a septic arthritis. You can have destruction of bone, soft tissue swelling. You can have something called like a spina ventosa lesion, which is like, destruction and lucency along some of your, metacarpals or phalanges. It's very aggressive. You can have soft tissue gas as well. Typically, it's hard to just it's hard for someone to say, oh, this is tuberculous arthritis without having lab tests and stuff like that. Typically we just say it's septic arthritis and then they decide what organism it is. But sometimes there can be like the spina ventosa lesion where you have like this, loose, loosened, destructive lesion in a bone, that can be a heralding sign for TB arthritis. Not very common in clinical practice in the United States.
Perfect. Okay. And then another question was, do you recommend ultrasound? And there are a couple of questions kind of, I guess they're asking about the role of ultrasound in arthritis.
Sure.
Um,
I love ultrasound. Ultrasound is actually my favorite modality for MSK. My residents will all tell you that. I think ultrasound is very good to look for, for example, inflammatory markers like tenosynovitis, synovitis in a joint. Finding erosions on ultrasound is hard. It's challenging because the bone, you're not sure if it's an artifact in the way you're scanning with the angle, or if it's like a fracture. You know what I mean? Like just irregularity along the hyperechoic bone interface on an ultrasound is very hard to definitively know if it's an erosion. Now, obviously, there are experts like John Jacobson who probably are amazing at ultrasound, and it's fine for them. But I think for the vast majority of MSK radiologists and stragglers like myself, it's very difficult to make that diagnosis with a high degree of confidence. But with that said, I think ultrasound is amazing for a lot of the soft tissue abnormalities in arthritis, like tenosynovitis, soft tissue swelling, a fusion, right, synovitis, and definitely for other things too, but especially for those type of things.
Awesome. Okay. And then had a question about how do you differentiate paravertebral ossifications of psoriatic arthritis from dish in the spine?
That's a great question. So they can look very similar, right? You have the flowing, but typically in dish, diffuse idiopathic skeletal hyperostosis is typically 3 to 4 flowing, bridging osteophytes that are comma shaped, but they typically is corner to corner as opposed to mid-vertebral body to mid-vertebral body. And it's 3 to 4 contiguous vertebral bodies, right? Typically in the thoracic spine, but it can happen anywhere. That's dish. Paravertebral ossification is dense comma-shaped ossification from mid-vertebral body to mid-vertebral body, and there can be skip lesions. Like it doesn't have to be contiguous, like 3 to 4. It can involve like L2, then go to L5. You know what I mean? That's actually common. That's actually very common for psoriasis. So, and it can go from one side, like on the right side, if you're looking at a coronal or like a frontal view, and it can move to the left side, right? So I think that's one helpful way to differentiate the two.
Great, awesome. All right, and then this last question here is asking about subchondral cysts and their association with CPPD,
Good.
if there's any.
Yeah, there is, for sure there is, right? So in CPPD, you get all the findings of OA, but in a different distribution, right? So you get subchondral sclerosis, subchondral cysts, spurs, and joint space loss. But typically, some authors have described that the subchondral cysts in pyrophospholipid arthritis tend to be bigger. They tend to be like, they're more dramatic. The subchondral cysts are like big subchondral cysts. That's not always true in real life, but that has been described in the literature. I'm sure it's probably on StatDX or whatever other resources that people use. But that is definitely something that we see in pyrophospholipid arthritis. But it's not super reliable, in clinical practice. I look for the other things like the distribution of like radiocarpal chondrocalcinosis, things like that to help me decide whether it's pyrophosphate arthropathy.
All right, excellent. I think that's it as far as questions go. Yeah, if we haven't answered any, please. Oh wait, sorry, there's one more I missed here. I apologize. Can you see chondrocalcinosis in ultrasound with a normal X-ray and a normal CT?
I was going to say, yeah, of course you can see chondrocalcinosis on an ultrasound, but I don't know the answer to that question. I don't know that there's any studies that show that you can see it on ultrasound first and where it's not visible on X-ray or CT. So I don't want to give a false answer. So I'm going to refrain from answering that question. But if the question was, can you see chondrocalcinosis on ultrasound? The answer is yes.
Perfect. All right, thank you. Yeah, I guess that's it for questions. I'll turn it over to Ozzy and Daniel.
Thank you so much, Dr. Awan and Dr. Farouk. This was such an amazing and interactive lecture, and hopefully we'll see you soon. Thank you.
Thank you so much, guys. Appreciate it.
Thank you. Bye.
Bye.
Thank you.